Yes, these acutely decompensating patient has most likely developed DIC. Obstetric complications, postpartum hemorrhage, placental abruption are a major cause of DIC due to a large volume of bleeding associated with these conditions. Significant bleeding can cause release of tissue factor thromboplastin, which leads to uncontrolled activation of the coagulation cascade and consumption coagulopathy. This leads to formation of the fibrin and protein-rich thrombi which consume platelets thrombocytopenia. Coagulation factor evidenced by prolonged PT or INR and PTT and fibrinolysis is then triggered to degrade the clot, triggered to degrade the clot, which elevates D-dimer, and depletes antithrombin and protein C and S. This results in paradoxical thrombosis, as in this patient who has developed symptoms of pulmonary embolus. The thrombi in the vasculature often also shear RBC, leading to microangiopathic hemolytic anemia evidenced by total bilirubin level. Patients with DIC require emergency supportive care, including treatment of the underlying etiology, uterine atony causing postpartum hemorrhage, and resuscitation with blood product and packed red blood cell and fresh frozen plasma. Okay, okay. Septic pelvic thrombophlebitis. This patient's presentation is consistent with septic pelvic thrombophlebitis, a complication with either pelvic surgery or the postpartum period. SPT is a thrombosis of the deep pelvic or ovarian veins, as seen in this patient's bilateral lower quadrant tenderness that becomes infected. Several factors predispose postpartum patient. Several factors predispose postpartum patients to thrombosis, hypercoagulable state of pregnancy, pelvic venous stasis and dilatation, endothelial damage from infection or trauma during delivery, because the most common etiology of the postpartum fever is endometritis. Because the most common etiology for postpartum fever is endometritis, patients are initially treated empirically with antibiotics. Persistent fever, unresponsive to broad-spectrum antibiotic therapy, and a negative infectious evaluation, blood and urine culture, urine analysis suggest SPT, which is a diagnosis of exclusion. Risk factor include cesarean delivery, chorioamnionitis, endometritis. Treatment is with anticoagulation and broad-spectrum antibiotic. Okay, box. SPT risk factor is cesarean delivery, pelvic surgery, endometritis, PID, pregnancy, malignancy. Pathophysiology, hypercoagulability, pelvic venous dilatation, vascular trauma, and infection. Presentation, fever, unresponsive to antibiotic, no localizing signs of symptoms, negative infectious evaluation, and diagnosis of exclusion. Treatment is anticoagulation and broad spectrum antibiotic. Is, uh, there is no fetal cardiac activity, so baby is died. Intrauterine fetal demise, isn't it? Is it symmetric or asymmetric? This is the is it that box? Because a head circumference, yes, biparietal. So it is first trimester, chromosomal abnormality. Okay, sorry. So uteroplacental, biparietal diameter and head 34, but femur length and abdominal circumference is 28. Oof. So it is second trimester, asymmetric. Asymmetric is uteroplacental insufficiency and maternal malnutrition. Am I right? Yes. This patient at 34 weeks of gestation has this patient with 34 weeks of gestation have an intrauterine fetal demise or childbirth. The underlying cause may be fetal. The underlying cause may be fetal, placental, or maternal. Therefore, evaluation include fetal study, autopsy, karyotyping, gross and microscopic examination, such as this patient antiphospholipid antibody syndrome should be suspected. APS increase the risk of vascular thrombosis, particularly during pregnancy. Commonly affected vessels are uteroplacental arteries, spiral artery, which perfuse the placenta. Uteroplacental artery thrombosis is the first trimester typi- typically result. Uteroplacental thrombosis in the first trimester typically results in pregnancy loss because the developing placental trophoblasts are highly sensitive to decreased perfusion. The effects of thrombosis in the third trimester are more insidious. Placental perfusion gradually decreases the point of uteroplacental insufficiency, impaired fetal oxygenation or nutrient supply, and fetal growth restriction. Fundal height 30 centimeter at 34 weeks. Because uteroplacental insufficiency develops gradually, the fetus can initially adapt by redistributing blood flow to the vital organs, brain, heart, at an expense of the abdominal viscera, which causes an head asymmetric or head sparing pattern sparing head sparing pattern of growth restriction. Normal head measurement by but lagging abdominal circumference. Once the oxygen and the nutrient supply decreases below the threshold for maintaining the vital fetal organ, and stillbirth occurs. Okay.
Obstetrics.
Okay. Amniotic fluid index. If it is oligohydramnios, causes are oligohydramnios is amniotic fluid index less than 5 centimeter, and polyhydramnios is if amniotic fluid index is more than 24 centimeter. Oligohydramnios preeclampsia, renal anomalies, Renal anomalies, uteroplacental insufficiency, preeclampsia, abruptio placentae, and NSX. Complication is meconium aspiration, preterm delivery, and umbilical cord compression, polyhydramnios, esophageal or duodenal atresia, anencephaly, multiple gestation, congenital infection, and DM. Complication is fetal malpresentation, umbilical cord prolapse, preterm pre-labor, rupture of the membrane. Amniotic fluid, tracheoesophageal fistula. Okay. So polyhydramnios. Amniotic fluid volume is maintained. Amniotic fluid volume is maintained via amniotic fluid production, fetal urination, and removal by fetal swallowing. A normal volume is required for fetal development, lung maturity. This patient has polyhydramnios and amniotic, excessive amniotic fluid more than 24 centimeter. In this case, polyhydramnios is due to an isolated fetal tracheoesophageal fistula that impairs fetal swallowing and removal of amniotic fluid. Most patients with polyhydramnios are asymptomatic. And have a uterine size larger than dates discrepancy. Fundal height fundal height 32 centimeter at 24 weeks of gestation. Others may have dyspnea due to insufficient maternal lung expansion from an enlarged uterus. Polyhydramnios, especially with increasing severity, can cause obstetric complication due to uterine overdistension and increased intraamniotic pressure. The increased tension of the fetal membrane makes them more susceptible to rupture. The increased tension of fetal membrane makes them more susceptible to rupture, placing these patients are placing this patient at high risk for preterm pre-labor rupture of the membrane. Uterine overdistension may also cause inflammation, prostaglandin release, uterine irritability, and the increased risk of preterm labor. Additional complications include fetal malpresentation, breech, umbilical cord prolapse, postpartum uterine atony. Patients with symptomatic polyhydramnios may benefit from amnioreduction, amniotic fluid removal by amniocentesis. Okay. Tay-Sachs, autosomal dominant. mm, Mm, okay. So prenatal screening algorithm for autosomal recessive disease. Maternal screening negative, no additional testing. Maternal screening positive, paternal screening negative, no additional testing. If maternal screening disease positive, paternal positive, definitive fetal testing, CVS or amniocentesis. Prenatal screening for a variety of the disease. Prenatal screening for a variety of the disease is a common condition of routine prenatal care that is offered to all patients for reproductive planning. This this screening approach is based on the patient's prevalence, how detrimental the disease is to quality of the life, and if there is available intervention to treat or improve the disease course. Tay-Sachs disease is a condition in which Tay-Sachs disease is a condition in which carrier screening is often performed because it is an autosomal recessive disease caused by hexosaminidase, a hexagene enzyme deficiency that results in progressive neurodegeneration and early childhood death. For a child to inherit an autosomal recessive condition such as Tay-Sachs disease, each parent must contribute one abnormal gene allele. In mother who tests positive for a pathogenic variant is an autosomal recessive condition, there is 50% chance that her abnormal allele will be passed on her child. However, in contrast to autosomal dominant disease, that this does not guarantee that this child will be affected. Therefore, the best step to evaluate the father for pathogenic variant, if the father has no abnormal variant, the child has no chance of inheriting the disease. In contrast, if the father is a carrier of abnormal allele, the child has 50% chance of being carrier one abnormal allele, 20% chance of having no abnormal allele, and 25% chance of inheriting the disease. Okay. Sorry. Oh, sorry. If both patients have pathogenic variant, then invasive testing like chorionic CVS, chorionic villus sampling, or amniocentesis or fetal DNA sequencing can provide an definitive diagnosis of whether or not the child will be affected the disease. The two abnormal allele. There is no acceleration. But heart rate is within the normal limit. 110 to 160, but uterine contraction is higher. Does not coincide. It is not uteroplacental insufficiency. It is not cord compression. Cord. Yes, there is no fever. Or it is medication. Oh, fetal heart rate. So it is. Look at the clinical significance of fetal heart rate variability. If it is absent, undetectable, or minimal, less than 5 beats per minute, then it may be CNS depressant. Then it may be CNS depressant, narcotics, alcohol, recreational drug, maybe temporary fetal sleep, maybe prematurity or fetal hypoxia, less than 5 beats per minute. If it is normal, moderate, 6 to 25 beats per minute, it is normal pattern. If it is more than 25, unclear significance. Okay. During labor, fetal heart rate monitoring is performed to continuously assess for signs of fetal hypoxia and metabolic acidosis, which can lead to fetal compromise. Fetal heart rate features that are monitored include baseline heart rate 110 to 160, presence of acceleration and or deceleration, and heart rate variability. Variability is the beat to beat fluctuation in baseline fetal heart rate. These fluctuations are irregular in amplitude and frequency, categorized based on amplitude change, measured from peak to trough. Mm, Normal variability, a change in baseline. A change in baseline from 6 to 25 is reassuring. In contrast, or minimal variability as in these patient can indicate fetal metabolic acidosis and impending fetal compromise. However, certain medication can cause transient absent or minimal variability unrelated to fetal acid bed status. Opioids, morphine may decrease the fetal heart rate variability due to fetal CNS depression. Exposed fetuses are typically have decreased frequency of accelerations. These changes are temporary and normalizes the medication effect diminishes. Therefore, these patients typically require only continued monitoring. Okay. Okay, it is intrauterine fetal demise, absent fetal cardiac activity more than 20 weeks of gestation. It may be due to aneuploidy, fetal or placental anomalies, fetal growth restriction, congenital infection, substance use, tobacco or cocaine, maternal conditions, hypertension, and diabetes mellitus. Evaluation fetal autopsy, gross or microscopic examination of placenta and umbilical cord, karyotype or genetic studies. Maternal is clay or Bacteris antiphospholipid antibody and congenital studies. Sorry, coagulation studies. Management 20 to 23 weeks, 20 to 23 weeks dilatation and evacuation or vaginal delivery, more than 24 weeks vaginal delivery. Complication coagulopathy after several weeks of fetal retention. I think that we you want me to read the explanation? Okay. Intrauterine fetal demise or stillbirth refers to fetal death more than 20 weeks of gestation prior to delivery. Patients often have decreased or absent patient could have patient often have decreased or absent fetal movement. On evaluation, no fetal heart tone are audible on Doppler sonography, and ultrasonography visually confirms the absence of fetal cardiac activity. The pathophysiology of intrauterine fetal demise can be maternal, fetal, or placental in origin. Therefore, Evaluation includes the following: fetal autopsy and karyotyping or genetic studies, gross and microscopic evaluation of the placenta for thrombosis, abruption, infection, or other disease, maternal lab testing for antiphospholipid antibody syndrome and feto-maternal hemorrhage, and other testing evaluation for thrombophilia, and cultures to confirm and exclude other etiologies based on patient's medical history. Identifying a possible cause not only provides patients with answer but also helps determine the recurrence risk and optimal management for future pregnancy. Even after thorough evaluation, up to half of the intrauterine fetal demise have no identifiable cause, and therefore patients should be counseled in advance. The testing may be negative. Okay. Yes. So these patients' postpartum hemorrhage and vaginal mass are concerning for uterine inversion and obstetric emergency. Uterine inversion risk factor may include fetal macrosomia, rapid labor and delivery, and placenta accreta. Uterine inversion likely occurs. Uterine inversion. Hello, can you hear me? Yes. Risk factor may include fetal macrosomia, rapid labor and delivery, and placenta accreta. Uterine inversion likely occurs due to excessive fundal pressure and traction of the umbilical cord prior to the placental separation, and can be lead to cord avulsion as in this patient. The excessive traction causes the fundus to collapse in the endometrial cavity and prolapse through the cervix, resulting in firm, round mass protruding through the vagina. As a result, the fundus is no longer palpable transabdominally. Patients with uterine inversion typically have severe abdominal pain, heavy vaginal bleeding, and a possible hemorrhagic shock, hypotension. Neurogenic shock due to traction effect of the surrounding peritoneum may also occur, resulting in paradoxical bradycardia. Okay. Okay. Uterine inversion is treated with immediate manual replacement of the uterus by placing a hand in the vagina and pushing the prolapsed uterus back through the cervix to return to its anatomic position. Delay in reduction of the prolapse can make manual uterine replacement more difficult because the uterus can become edematous and the cervix may contract around the inverted uterus. If the placenta is still attached to the uterine wall as in this patient, it should not be removed until after the uterus is replaced because the risk of massive hemorrhage. Manual replacement of the uterus requires moderate uterine relaxation, and therefore uterotonics oxytocin are discontinued because they increase uterine tone contractility and may make manual uterine replacement possible to perform. Uterine relaxant terbutaline are typically reserved for patients in whom attempts at reduction are unsuccessful because such relaxant increase the risk of persistent uterine atony and associated PPH. If attempts at manual uterine placement fail, the next step is laparotomy to prevent exsanguination. Okay. She has not done early dating. Early, early ultrasound. Early ultrasound is done when six regular. She does not, and there is by 15 weeks and irregular contour. Five, is it fibroid? So this patient has a uterine size greater than the death discrepancy 15 weeks size uterus at 9 weeks of gestation on her last menstrual period. A size greater than death discrepancy usually has an obstetric cause such as incorrect dating. The most common cause is multiple gestation polyhydramnios or gestational trophoblastic disease, iridiform mold. However, none of the above conditions would produce an irregular uterine contour in early pregnancy. An abnormal uterus is more likely in this patient with an irregular uterine contour and history of heavy means. The most likely cause is leiomyoma uteri. Leiomyoma are benign uterine smooth muscle tumor are the most common cause of pelvic tumor. Fibroid shear, clinical feature uterine enlargement, constipation with pregnancy. Other signs and symptoms vary by fibroid size and location. Leiomyoma on the uterine surface subserosal and within the uterine wall intramural are most likely cause of enlarged uterus and irregular uterine contour and bulk symptom, pelvic pressure and constipation. Submucosal fibroid located beneath the endometrium can cause prolonged and heavy menstrual bleeding with painful cramping, dysmenorrhea in non-pregnant patient. This patient likely has all three fibroid types. Although most fibroids do not adversely affect pregnancy, having large multiple fibroid can increase the risk of obstetric complication, spontaneous abortion, preterm labor, PPH, and the rate of cesarean delivery. Okay, yes. Is it abductions or Arb's palsy? Is pronated and wrist is fingers are flexed. So this infant's delivery was complicated by shoulder dystocia due to high birth weight. Several maternal risk factor, advanced maternal age, obesity, multiplicity may contribute to fetal macrosomia, birth weight more than 4.5 kg, and application of extraction and neck while extracting trapped infant can cause injury to the brachial plexus. These patients common type of injury. Sorry. On the most common type of brachial plexus injury is Arbutus palsy, which involves the fifth, sixth, and sometimes seventh cranial nerve C5 to 7. Weakness of the deltoid and the infraspinatus muscle innervated by the C5 and biceps and wrist extensor biceps and wrist extensor innervated by C6 and finger extensor C7 leads to predominance of the opposing muscle. This the resulting appearance is the characteristic waiter stiff posture as seen in this patient. Management involves observation and physical therapy because up to 80% of the patients have spontaneous recovery within 3 months. Prognosis prevents on whether the damage of the resulted from mild nerve stretching or compressing as opposed severe rupture or avulsion. Surgical intervention, nerve graft reconstruction, decompression can be considered for infants with no improvement by age 3 to 9 months, but is necessarily curative. But it is not necessarily curative. Okay. Why she is on aspirin? Is she has preeclampsia? And she look, her C-section is done by classic C-section. That means vertical section is given. Normally C-section is given via Fenenstein incision. Like in such not vertical, it is horizontal So as if somebody is on classical cesarean section, you cannot do vaginal delivery on those patients because it is risky. Another thing in here, like she has preeclampsia. So preeclampsia is an indication of cesarean section. Look, her first CS is done via CS. Sorry, her first cesarean section is done at 25 weeks of gestation due to eclampsia, isn't it? Mm, may not be. So it is classic CS. There are some absolute contraindication of I do not I don't remember. Mm, I need to see. Can you find the absolute contraindication in the Gemini? Like absolute contraindication of cesarean section? Sorry, absolute contraindication of the vaginal delivery. Mm, there is new AI in the market. You can use that too. Yeah, yeah, placenta previa. Yes, placenta classic C-section, active genital herpes, placenta previa, not okay. Placenta previa. I was thinking the preeclampsia. Okay, placenta previa. Okay, you can use Grok. Grok is the AI made by Elon Musk. Okay, people are using AI. Lots of people, as we are from the medical sector. That's why we do not have that news. But those who are other sector, they are using AI. Okay, patients with breech presentation, a fetal malpresentation in which buttocks or feet are the buttocks and feet are the fetal parts closest to the maternal cervix are typically managed with a scheduled cesarean delivery at term. This is because vaginal deliveries have a higher rate of complication, umbilical cord prolapse, asphyxia compared with the cephalic vaginal deliveries. Those with breech presentation who do not want to have scheduled cesarean delivery can sometimes be offered an external cephalic version, a procedure in which the fetus is manually rotated to cephalic presentation to allow for vaginal delivery. A classic cesarean delivery, as in this patient, is a contraindication to vaginal delivery regardless of fetal malpresentation due to risk of uterine rupture. A classic uterine incision is typically performed at very very early gestational age when underdeveloped lower uterine segment cannot accommodate a low cannot accommodate a low transverse horizontal incision. It involves a vertical incision through the upper contractile portion of the myometrium because these area generates high intrauterine pressure during labor. The myometrial scar is less likely to withstand the presence caused by the labor contraction. As a result, there is an increased risk of uterine rupture and obstetric emergency. In a contrast, a low transverse cesarean delivery involves the contractile lower portion of the uterus, a scar in the area, and has a significantly lower risk of uterine rupture. Mm, Okay, okay. For patient with prior classic cesarean delivery, external cephalic version is not typically offered, and a repeat cesarean delivery should be recommended, regardless of whether the patient would like to attempt a vaginal delivery. Repeat cesarean delivery is typically performed between 36 and 37 weeks of gestation to decrease the risk of spontaneous labor and subsequent neonatal and maternal complications. Other contraindications to vaginal delivery include placenta previa and prior extensive uterine mammectomy. Okay, yes, okay.